Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Doing quite well. Thank you.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute's Facebook page. Today, Dr. Murphy will be answering viewer-submitted questions, addressing the latest headlines and our lone U.S. COVID statistic through today, November 14th. We invite you to submit any questions or suggested topics down below in the comments or at any of our social media linked in the description. Starting with our COVID statistic. Average COVID deaths per day in the last reported week were 62. The same week in 2023, we saw 184. Dr. Murphy, your reactions to those numbers and the state of COVID in the country.
Well, it's still 62 deaths per day, but it's much less than last year. So this trend we're seeing as the immunity develops across the population due to COVID infections and number of vaccines given, that this whole process will continue on this downward trend. It'll level off at some particular point, but this is, of course, a very good sign. As far as the strains that are circulating, a new one has popped up called MC1, which makes up 6% of the cases. So far, it behaving like the other ones, but because it is taking over, that means it's actually even more contagious than the ones that were circulating, like KP311. So they do the wastewater surveillance system is showing low amounts of virus, and so it's going to continue to come down as we go into the winter respiratory season. So we'll see an uptick starting really in December.
Mm-hmm. And some more good news leading into the respiratory season, hopefully, is that a clinical hold for a recombinant or combination flu and COVID vaccine has been taken off clinical hold. Can you tell us about it?
Yeah, this is Novavax. They had this is the older original vaccine technology, not the mRNA technology. So they had a combo COVID flu vaccine, one injection. Then you can get both things in one injection. So a person had a very serious side effect, and it was originally reported as motor neuropathy, but it later turned out that the person was just being diagnosed with amyotrophic lateral sclerosis, another neurologic disease that's unrelated. It just happened to show up. And so the event was considered not related to the vaccine. It's the person has another disease altogether. So they lifted the clinical hold, and they will begin enrolling in their phase 3 study now. So this combination vaccine would not be ready until next year at the earliest.
Mm-hmm. Well, very good news. We'll stay up to date and hopefully get that trial data as soon as it is available.
It's a convenience factor.
Mm-hmm. Absolutely. And sticking with COVID for now, there was another really interesting study using AI to estimate and find how many people in the US actually have long COVID. Can you tell us what the researchers and their algorithm found?
Yeah, so this is an interesting longitudinal electronic health record finding in Massachusetts that involved 295,000 patients from 14 hospitals and 20 community health centers in Massachusetts. And they used this algorithm, this AI algorithm, and they found that really 23% of the people who had COVID ended up with their definition of long COVID. So that's 3 times higher, at least, than the 7% that has been knocked around for actually years now. So they found really quite a few patients. So they identified this 24,000 person cohort with about 80% precision, and ended up with a 23% case rate for long COVID. So it really, there's more people having problems from COVID than long COVID than originally thought, according to this data from at least this group in Massachusetts. So almost 300,000 patients.
Very, very interesting. And we will continue to watch the long COVID numbers and research as we know it's a topic of interest. But before we move into those submitted questions, there was a quick update from the CDC regarding the beginning of this respiratory flu season. Can you tell us what they shared?
Yeah, so a couple cases of flu have shown up already. It usually starts in early December, but I mean, it's happening in October also, but at a very low number. So the first child death, unfortunately, of the season has been reported. Last year, the number of children dying from flu was 204. And I mean, this is, very unfortunate and sad. And remember, this flu vaccines are recommended for everybody 6 months and older. So it just shows you that everyone should get the flu vaccine, because of course, this will impact the mortality rate in these young kids as well as in adults.
Mhm. And our first submitted question is also on a vaccine, but not the flu vaccine, the respiratory syncytial virus RSV vaccine. Our viewer asks and states, it's very good news that pregnant women can get the RSV vaccine to protect their child. Which trimester is best for the mother to get this?
Yeah, so this is, we know that the antibodies to RSV will significantly decrease the amount of RSV in children, which is one of the big groups having problems, is besides the older people that get it. So these kids under 1 year of age are very much at risk. It can fill up the ICUs and hospitals with sick kids with RSV. And there's been some very nice studies that show that pregnant women who take the RSV vaccine in their third trimester of pregnancy will develop antibodies that are passed to the baby that give the baby, the infant, when it's born, protection against RSV. So that's approved. CDC currently recommends pregnant women should get a single dose of the maternal RSV vaccine. It's the Pfizer Abrisivo vaccine in the third trimester of pregnancy, and they should take it sometime between September and January. So if your third trimester is between September and January, you can take it. Alternatively, if you can't get that, there is this monoclonal antibody called Beyfortus, but there's been supply problems with that. There's not enough of it around. And they don't even, there's no way they can really make enough for every pregnant woman. So it's just another alternative to protect the babies for the mothers in the third trimester.
Mhm. Now, our next submitted question is on topic, but a little bit out of our scope as we try to avoid politics. However, a very important question. The question reads, I want to know, are they stopping with COVID vaccines because the new administration say they are? RFK said they are getting rid of all vaccines. I would love to know that because that could be horrible. Your opinion and expertise, Dr. Murphy.
If we get rid of all vaccines, we're in a lot of trouble. There's gonna be a lot of dead bodies around, and especially children, unfortunately. So we don't know what's going to happen. We don't know what position Mr. Kennedy is going to have in the new administration, and we don't know what rules can go in place. We also have to remember that the CDC makes guidelines. They can do whatever they want with the guidelines, but the states actually have the power. Now, RFK could say, we're not going to recommend any vaccine. I mean, that would be the worst case. But Illinois or some other state could just say, we're going to give vaccines just like we always did. So that can happen. In Florida, what's happening is the medical director of Florida is also an anti-vaccine person and has sent letters to every citizen in the state, supposedly adult, saying, don't take the mRNA COVID vaccine. I mean, this is very unusual and unwise recommendation. But, you know, the states basically can do whatever they want. So the Constitution of the United States doesn't mention anything about healthcare. Healthcare is a state-run operation. So we can, the federal government can, you know, coordinate data, make recommendations, but the power is in the state. So it's going to be up to whatever state you live in, whether they're going to promote these vaccines or not promote the vaccines.
Well, that is very good to know, and at least somewhat reassuring. But again, we will have to wait and see. But moving on to a very, very big headline this week out of Canada. A teenager or young person has been suspected to be infected with the avian flu and is in critical condition. Can you tell us about this case?
Yeah, this is just one case, but this is a very important case. This is a young teenager, we don't know, male or female, from British Columbia, who is hospitalized in critical condition. That means they're in the ICU. They have avian flu. They don't work on a farm. There's no exposure to poultry or to dairy cows or whatever. Person presented with conjunctivitis, which is rather unique for avian flu, fever, and cough, and the person is very sick. He doesn't have any underlying other health conditions, and he's receiving intravenous antiviral therapy. So this is very disturbing because all the cases we've reported to date in dairy farmers and poultry workers have been mild. Now, if you look back historically, globally, in other countries, the mortality rate for avian flu had been very high, up to 50%. So we were always waiting, what's going to happen when avian flu gets into the population. They have no idea how this person got exposed. They're treating the people that have been around that person with the flu drug that's out there, Tamiflu. Nobody else has gotten infected. And they don't know how this happened. The person did have some pets. The pets have been tested, but the pets don't seem to have it. It's very disturbing. So why would a young person be so sick? It's similar to what happened in the 1918 flu pandemic, where a lot of young people died from the flu. And the thinking was then, and maybe here, that the younger adults who have no immunity to flu or avian flu in this particular case, actually, since they have no immunity, they're going to have more severe disease than, say, a dairy farmer in the 30s, 40s, 50s, 60s who's had flu a bunch of times and multiple flu shots. They might have a little immunity that keeps them from getting so sick. We don't know if that's the case. That's a hypothesis. But anyhow, this case is going to be watched very closely because this is yet another case, avian flu. So there are stockpiles of avian flu vaccine that are out there, and they're sort of ready to go with it. And when they pull the trigger, then who is going to be getting this? We don't know why this kid has it. So it's all being investigated now. The Canadians and British Columbians in particular have a great medical system. They're doing all the surveillance and investigations, and we'll see what happens. So it's a case we're going to watch very closely.
Absolutely, and that much of the medical world is watching very closely as well. And going back to COVID, just for one more story here, there was an overarching analysis, more literature review run by several institutions to look at anaphylactic and allergic reactions to COVID vaccines specifically. Can you tell us about the rates that they found?
Yeah, so 3 different groups are looking at allergic rates to COVID vaccines. One is the Harvard School of Public Health, one is a Spanish medical group in Malaga, Spain. And the third is the Kaiser Permanente Southern California group. And these are large studies. The Kaiser group is 391,000. And the Spanish group is 429, but people who are very high risk for having a allergic reaction. In other words, they had been allergic to vaccine components in the past. And what they found was very few allergic reactions, but they did have some. In the high risk Spanish ones, they found that 3 people developed anaphylaxis. That's shock. But they all responded to parenterally given epinephrine. So that's like a EpiPen. For those people that have allergies, they'll know what I'm talking about. It's a single dose epinephrine injection, but it doesn't have to be the EpiPen. It can be just epinephrine given. And it can be given sub-Q or intramuscular or whatever. But anyway, all the patients that got the epinephrine, they did fine. And it's an allergic reaction that happens relatively quickly after you take the vaccine. So the components in the vaccine that people are allergic to are referred to as PEG, and PS80. These are components in the vaccine. And a lot of people know that they're allergic to that because they're having problems with other vaccines as well. So you look at all 3 reports here, severe allergic reactions to COVID-19 vaccines are exceedingly rare. And the mechanisms require further investigation. But everyone needs to continue to follow this. And, if somebody's got some history of allergy to vaccine, it has to be done under monitored conditions with the availability of epinephrine nearby.
Mm-hmm. Well, switching gears to something we spoke about last week that has continued to rise here in the US, pertussis or whooping cough. There's more data out of the state of Washington and just general whooping cough. So, can you explain that all to us?
Yeah, I mean, part of the problem here is that the kind of reluctance to take vaccines, not necessarily anti-vax people, but just a reluctance to stay up to date with the vaccines has led to a sharp rise in whooping cough, which is caused by a bacteria, Bordetella pertussis. And this is, this increase is 5-fold. This is actually quite dramatic. You can die from whooping cough. Some 300,000 people, mostly kids per year worldwide, die from it. In the United States, because the medical system is otherwise pretty strong and can support these kids, it's about 20 children per year, mostly kids per year, die from it. So, I mean, they can get very sick, and there are a few deaths, and the numbers are really increasing significantly. And it's due to the lack of keeping up with the vaccines, because the vaccines have to be given periodically throughout your life.
Mm-hmm. Something like almost 500 cases increased from just last week to this week. So, we're really seeing skyrocketing numbers.
Numbers are really up, and it's all just because of not keeping up with these vaccines.
Mm-hmm. Now, our final story, looking globally, is a really great example of when public health action is taken very quickly and effectively. Rwanda has announced that they have discharged their last Marburg virus patient. Can you tell us what that means and how they handled this so efficiently?
Yeah, so Marburg is very nasty virus, kind of like Ebola. It's a lot of people can die from it. It was some people working in a mine outside of Kigali, the capital of Rwanda, and then people were in contact with those people and people in the hospital taking care of them. So there was this outbreak. So just putting in good, solid, universal precautions and keeping everybody isolated and using the appropriate equipment and shields and gowns and gloves and whatever has caused the numbers just to plummet. And so just good public health measures has worked. Total number of cases was 66. There were 15 fatalities, so about 25% or so mortality rate. So they're lifting the restrictions, but they're still actively following anybody who was in contact with anybody who was sick. So that's it's really good news that this has been taken under control for so long. We had block travel to Rwanda. We have several projects ongoing there. Many other people too stopped going, but I think this is all kind of resolving now.
Well, that is excellent news. And on that note, I'd like to thank you, Dr. Murphy, for your time and expertise. Thank you again for a great episode.
Hey, thank you.
And thank you all for joining us for this week's episode of the Ask Dr. Murphy series. We hope to see you again next week. And as always, if you have any questions or suggested topics, please leave them down in the comments or at any of our social media linked in the description. Have a lovely weekend.
Great. Thank you. You too.